head of surgery in the Tainan Chinese Medical University in Taiwan. Jim is going to talk to us about endovascular treatment in complex aortic arch diseases.
Thank you, Professor Chen, for your kind introduction. First of all, I'm quite envious about the previous speaker because they have access to the endograft, the branch endograft, inner branch. In Taiwan, we are because of the policy, we can't access to this kind of product. So my talk we will build like the real world experience with without so many available access. I think under circumstances that we can do total endovascular treatment of a complex arch disease. In our previous experience, because we don't have those access to those branch or fenestrated device, so we have accumulated a lot of experience with chimney and perigraft experience. Like we have a complex TAA we can do with a chimney perigraft with 5 years survival. And also we have limited experience to this off-the-shelf T-branch. It's not custom-made T-branch. And also with a very complicated case, we can do octopus. And sample case, we can have a 1 year much better result. And also for some cases with ascending aortic rupture, that this patient is presented with ARDS because of the rupture of the ascending aorta. We can do the TEVAR under circumstances. So for the arch, I think good landing zone is very critical. And then for me, because I'm a cardiovascular surgeon, for those aorta larger than 4 centimeters, I will go directly to do surgery, at least to give the patient a very good landing zone. And I think for the stent graft, without any chimney, anything, just stent graft TEVAR, I think we should at least have 2 cm of sealing zone. So it's very important. So about the seal and fixation, and I think less manipulation is less stroke in my practice. So for my practice, I use the stent graft with proximal bed string because for that, I think I can use the bed string to cover some branch without compromise the branch, and I can have some of more sealing zone. And then I think it also provide alignment with proximal sealing. So in additional to TEVAR, we can have a hybrid repair, the branch device, chimney periscope, and on-table fenestration, and also the in-situ fenestration. And in my practice, I do a hybrid arch for those cases with arch or the ascending aorta larger than 4 centimeters if we needed to treat the complex arch. So we do the very good brain protection. I think that for elective case, the mortality can be lower than the 10%. And in our previous speaker, they talk about this inner branch device, but we don't have experience. This is a study from the Seven Holland, the London and France group, where in the 40 patients which focus on the post-dissection arch and thoracoabdominal aneurysm, where they have quite a good clinical success with in-hospital mortality 4.7%, but quite a lot of reintervention, including early and late reintervention. And this is a study from Dr. Tilo, when he have 53 patients just focus on the arch branch endograft, where they have a less stroke, so 5.5%, but still there's a 7.4% posterior mortality, and reintervention, there's still problem with the reintervention rate. So for me, because we don't have access to those, so for me, I think chimney periscope is much easier because it's off the shelf, and the device it can adapt in many different situations. And mostly because the device is lower profile because it's just a TEVAR stent graft, so it's useful in the hostile iliac access and also lower cost and shorter procedure time. This is how I do with the chimney because in Taiwan we have more dissection than the aneurysm case. 70% of my practice is a dissection patient. So most type A repair we do the common carotid, the left carotid anastomosis, debranching. So mostly we do now is just one single chimney or double chimney. And as you can see in the picture, that's how we do the chimney. And in certain cases that we did not debranch earlier, so the residual type B dissection, if we treat it, we use triple chimney. So this is in the past 5 years, we have 140 patients we've done.